And we will go ahead and get this going. So welcome to everybody. This is our August Becoming Baby Friendly in Oklahoma webinar. And I'm Becky with the University of Oklahoma Health Sciences Center and our Oklahoma Breastfeeding Resource Center, clinical assistant professor in the OB-GYN department and adjunct in pediatrics, and then also the project lead for Becoming Baby Friendly in Oklahoma. So I know I've visited many of your hospitals, or the hospitals of those of you that are on the call today. So welcome. Let's see if I can advance my slides. No disclosures, of course, as usual. This project and the webinars that we provide through this project are supported by a Title V federal grant to the maternal child health section of our Oklahoma State Department of Health. So we are very, very appreciative to have the opportunity to provide this support to our hospitals around the state, and to know that we have strong support from our state health department for hospitals to achieve baby-friendly designation. So always good to remember that. And just a quick picture of our team. Whoops, now that slide got timed. Don't do that. Of course, myself, and then Petra Kalindras, who also runs our outpatient clinic, and then Sarah Bellotti, who keeps our house in order. She's our team administrator and helps keep us very organized. So, of course, we are in August, and we've had World Breastfeeding Week move on down the road, and we're still, though, in the middle of National Breastfeeding Month. And for those of you that aren't as familiar, perhaps, with the fact that we have a whole month to celebrate breastfeeding, sometimes I like to say that we still have so much work to do with improving our breastfeeding outcomes that a week is just not enough. We need a whole month to raise awareness about this issue. But anyway, that was excuse me, established a few years ago by the United States Breastfeeding Committee, so our kind of national organization there that oversees all things related to breastfeeding. Anyway, and we, got some background noise, so just reminders too. If you're, on the phone or in the office or whatever, be sure to put yourself on mute unless you want to stop and ask a question. But please do not put us on hold if you're on the telephone, because we will get the music, recorded music that's in the background on many hold systems. So just some reminders on that. Anyway, I don't know if we have anybody on the phone or on the webinar today from Hillcrest, but just a reminder, we said this, I think, last time, but congratulations to Hillcrest Medical Center, who achieved baby-friendly designation just a couple months ago. So we now have 8 hospitals that have been designated, and that means over 20% of our babies are born in a baby-friendly hospital. And some of you, if you're on the email list for Baby Friendly USA, may have seen the notice that came out from their office that we hit 25% of hospitals nationwide, and we hit the really, really great bar of 1 million babies born in a baby-friendly hospital. It's because we have about 4 million babies that are born in the United States each year. So that was pretty exciting news too. So obviously we're proud of the progress we've made, and yet the rest of the country seems to stay a little bit ahead of us. So anyway, so with August being National Breastfeeding Month, USBC each year has identifies and kind of, sets a theme or a particular topic for each week to raise awareness. So week 1 this year was Policy Pulse. Week 2, which is the week that we're in currently, is Special Circumstances and Emergency Preparedness. And week 3 is Call to Action. And actually, we were just at the USBC national meeting, and so week 3 is when the CDC will be releasing the 2018 breastfeeding report card. So we will be eager to see that, and that's where They include not only the most current breastfeeding rates that they have for the nation and individual states, but a lot of the other parameters, outcome measures that they monitor, and they're releasing this breastfeeding report card on a, let's see, do we say biannual? Is that every 2 years basis now? So 2018, the last one was 2016. So look for that or look for information on that next week, and we'll certainly notify everybody as well. And then last but not least, every year now, the last week of August is Black Breastfeeding Week to really celebrate and raise awareness of the disparities that we continue to have in our breastfeeding rates, and that the women of color continue to have the lowest initiation and duration rates. So to help bring attention to that, and then also to help normalize breastfeeding in families of color. So let me get that thing off my screen. Anyway, for more information on resources and information about each of those weeks, themes for each week, you can go to the U.S. Breastfeeding website. Our Oklahoma Breastfeeding Resource Center has also been trying to post different things on our Facebook page as well. That will help, celebrate each of those topics. So, and then last but not least, just as we get, feedback from events around the state, that Duncan Regional had a World Breastfeeding little community kind of latch-on event, and they had 100 families attend a week or so ago. So that was pretty exciting to hear. And more events, of course, down as the month goes on. Let me get this going. Here we go. Just, a couple more announcements. So our state Coalition of Oklahoma Breastfeeding Advocates, hopefully most of you are familiar with that. I'm on the board of directors again, and we are actually this week having some virtual town hall meetings. So those are just scheduled to be kind of informal sessions to give some updates of what's going on with your state breastfeeding coalition, and then to get feedback from members too. What are some of the issues and challenges that people are facing around the state, and how our coalition might be able to help address some of those. So we have another one of those. Meeting number 2 is actually this afternoon at 3 o'clock. And then the third and final one is Friday morning at 11:30. So all of that information is on the new events calendar that's on COBA's website. So you can go to okbreastfeeding.org and also see a lot of really good information from your state coalition about resources around the state, information for healthcare providers, information for families, what are our breastfeeding laws, and then what's going on here is COBA's activity or events calendar. So definitely check that out, and you certainly feel free to email COBA as well if you have a training or some kind of a community event or something breastfeeding related that you would like on that calendar. So you can definitely contact us at info@okbreastfeeding, and Ruth Piatak is our secretary on the board and can certainly follow up on that for us. And I think Ruth is actually on the call too, if I saw your name up there earlier. And let me just make sure, I hope everybody's hearing me okay. And let me just double check. All that's good. Okay, we'll move that out of the way. There we go. Okay, so our topic today, and actually what we decided would be a good kind of theme for several of our webinars now that we're in a new fiscal year, is to maybe take a little bit of a deeper dive into the evidence behind the 10 steps, which are as many of you know, are the foundation to the Baby Friendly Hospital Initiative. So we're starting today with the evidence behind Baby Friendly steps 1 and 2. So step 1 is about the policy, and step 2, of course, is about the staff training. So we're gonna I'm going to cite several sources. So I just wanted to get this little slide out of the way so I don't have to clutter up all my other slides. But we'll take a quick look at what the Baby Friendly USA guidelines say about steps 1 and 2, and then and really kind of the impetus for this this theme this year was a recent publication from the World Health Organization that came out last fall called their guideline for and very confusing. Some of you may have been on the webinar in June with Trish McEnroe from Baby Friendly USA, because they put out 2 documents fairly close together, and they had almost the exact same title. And this one that I'm going to cite a little bit from today was their more recent overview of the evidence behind each of the 10 steps, but it didn't specifically say that in the title. Anyway, but then you see I'll have some information also from the Agency for Healthcare Research and Quality. That just came out last month. An article from Maternal Child Nursing, and a couple from Breastfeeding Medicine, looking at the impact of the Baby Friendly Hospital Initiative on outcomes. So kind of try to tie all of that together. So what does Baby Friendly USA, what do their guidelines and evaluation criteria say about these 2 steps? So I just, actually copied some of this language so I don't misquote. These are important elements in the 10 steps. So step 1 is have a written breastfeeding policy that is routinely communicated to all healthcare staff. So I'm going to actually pause here for a second and see if those of you that are, on the either on the phone or on your computer, if you want to unmute yourself and maybe just chime in and let me know if you are aware that your hospital has a written breastfeeding policy or infant feeding policy. Sometimes, they may make it a more global name. So any comments from anyone that's on the call today? I know Vicky's from Integris Baptist, and I know certainly they have one. And I know we had someone from St. Anthony Shawnee, and they're, of course, working hard on Baby Friendly, so probably have one. And then I say, okay, Christy Wilson says OSU has one. Great. Okay. So we've got, yes, a few on the call. And then April, yes, we at Duncan, of course. Duncan is moving along quite rapidly on their baby-friendly journey. So exciting work happening down there. Okay, so step 1, and I'm going to see if I can do this little drawing tool. Where's the highlighter? There we go. So I'm not going to read all of this, but I just wanted you to know that this came directly out of oh, good. We've got Cheryl and Leah from Hillcrest. And I already said congratulations to y'all, so on your baby-friendly designation. Anyway, so your policy should say that, and Canadian Valley. Okay, thanks, Melinda. Breast milk should be the standard for infant feeding. And what I really like about this, let's see if I can make this work, all infants in the facility should be considered to be breastfeeding unless, after giving birth and being offered help, the mother has specifically stated that she has no plans to breastfeed. So I really like if we think of breastfeeding as the biological norm, if you will, then I like to say that should be our default mode, that we assume everybody is breastfeeding until we are told otherwise. And so, we may identify mother. This is not to say that we're supposed to hound mothers after delivery, but certainly if we've identified prenatally, she's received prenatal education, but it's in our policy that, we've once she's delivered the baby, moms can change their mind. And we've implemented step 4, which is that early immediate skin-to-skin contact, and offer, help. And if she's like, oh, I'm not breastfeeding, I said that should be in my chart, I haven't changed my mind or anything, okay, fine. Then we document that and we respect that, and we support that mom to safely feed and bond with her baby as well. So then the other piece that I thought was really important is down here towards the bottom. Policies of all departments will support and will not countermand the facility's breastfeeding policy and will be based on recent and reliable evidence. So I think that's important too. That certainly kind of adds another element for your baby-friendly task force to keep in mind. So to give an example of, what would that mean? Well, it would mean the mother that's just delivered and then has to go to radiology for a CT scan, and then the radiology tech, without any policy or evidence, just makes the assumption that the mom can't breastfeed for some X period of time after that procedure, without looking into what type of contrast agent was used, was it radioactive, et cetera, so that, they need guidance as well so that they don't undermine what should be happening for that mom. Does that make sense to everybody? All right, now how do I get out of this? Advance. Hello. All righty. To get rid of non-drawing mode. Let's see. There we go. Okay. Whoops. All right. Now that did not help at all, did it? Okay. And that's going to transfer to all of my slides. Joy, joy, joy. All righty. Okay, so bear with me for a second and let me see if I can get rid of this. There we go. Okay. Yay. Okay. Okay, so that's kind of just, quick overview of what step 1 actually says. And then step 2, staff training. So maybe we won't use the pointer thing, the highlighter. And this is the one that is often the hardest or the most costly as well for hospitals to comply with or implement. And that's training for nursing staff should be a total of 20 hours. So that's the 15 hours of didactic, oftentimes some kind of online training, such as we offer through OBRC, and 5 hours of clinical experience. And then healthcare providers, such as your physicians, midwives, and advanced practice nurses, with privileges in your maternity area. So labor, delivery, maternity, nursery, newborn care should have at least 3 hours of breastfeeding education pertinent to their role. So, for example, the OBGYNs, the pediatricians, the family medicine physicians should all understand the health impact, the importance of breastfeeding, some basics of breastfeeding management, but we're not going to expect the pediatrician to go in there and be doing, a breast exam and helping the mother with hand expression and things like that. They need to know maybe what it looks like and then who can help the mother with those things. So pertinent to their role. And then, and so everyone should have an understanding of, exclusive breastfeeding, some physiology basics, and their specific field of practice. And then last but not least, of course, is safe medications. Okay, and as y'all know, and those of you that have actually gone through an assessment or gone through a mock survey with us, while the physicians, clinicians are required to have 3 hours and the nurses are going to have 20, they all get asked the same questions on an interview. So there you have it. Okay, so any questions on that so far before I jump into some of the evidence behind some of these? I'll pause there for just a second. Okay, so let's look at the World Health Organization's guideline, or what I kind of subtitled their review of the evidence to support the 10 steps. And this is actually a picture of what it looks like. You can download this off the internet. It's hundreds of pages. So we certainly aren't going to go through all of the somewhat technical language that's in the document. So I've actually just got a very brief summary of some of the statements in there. But first off, who was this document intended for? Well, of course, the World Health Organization is usually focusing their publications on, high-level policymakers and maybe, the expert advisors in organizations or institutions such as universities or other national organizations who have some responsibility for programs involved with infant and young child feeding. So we don't just say breastfeeding, because the World Health Organization considers, that breastfeeding may continue for 2 to 3 years. So we're not just looking at infant feeding, but infant and young child feeding. And how does that infant start to transition from exclusive breastfeeding to breastfeeding and complementary feeding with safe, appropriate complementary foods too. So that's, another whole topic, but certainly not something that our baby-friendly hospitals are typically involved in. And can also certainly be used by healthcare professionals and, academic institutions to help disseminate this information. So they may use it in some of their training programs, for example. So that's the specific target audience. And so they included, they kind of broke the 10 steps down into 2 or 3 sections. And so one section is about, the clinical practices and helping mothers, the steps 4 and 5 and 6 and so forth. But then some of the steps really they put under this concept of creating an enabling environment. So the mother can't create this environment. The hospital or the institution has to create an environment that enables successful breastfeeding. It's not about we're going to make everybody breastfeed, but we're going to create an environment, once again, where mothers are more likely to be successful with breastfeeding. So anyway, so the question they had in this document, question 1, should hospitals have a written breastfeeding policy to increase rates of early initiation of breastfeeding? So that was really their question, and that they reviewed the evidence. And to give you just, the overall summary of what they found, they stated that the overall quality of the evidence at this point in time was very low. So now that doesn't mean that step 1 has no value and that hospitals are wasting their time having a written breastfeeding policy. It's really a call for more research, that we haven't had either enough or the right type of research to specifically answer this question. And so if any of you were on the call or the webinar, in June with Trish McEnroe, she also talked about one of the frustrations that Baby Friendly USA, a lot of other major organizations involved in breastfeeding and baby friendly hospital practices. It was frustrating that this review of the evidence that the World Health Organization put together, they really strongly focused on randomized controlled trials and the different types of RCTs that you can put together. And they really, what's the word I would say, really gave little to no value to any epidemiological or observational type trials. And so one of the challenges I think that we have, and we continue to see in something like this in the field of breastfeeding and lactation, is it's really hard to do a randomized controlled trial and answer a lot of these questions. So, how would you randomize this question? Do you go out there and take hospitals that don't have a policy, and then you compare them to hospitals that do, and well, there's already some bias there? Or do you go out and you find a group of hospitals, that none of them have a policy, and now you're going to work with, the one group of hospitals to implement a policy, and you're not going to do anything? So there's just, it's really hard to, I think, design those types of trials. And so, anyone that's on the call today that has, other perspectives, feel free to unmute yourself and raise a hand or make a comment or type something in the chat box. So, okay, so step 2 from WHO, once again, under this creating an enabling environment. So this is what the hospital or the birthing facility can do to enable more success with breastfeeding, is should staff be trained on breastfeeding and supportive feeding practices. So there's your breastfeeding and your formula feeding families. So should they be trained on breastfeeding and supportive feeding practices in order to increase rates of early initiation? If we train the staff, is that going to impact our breastfeeding initiation? Of course, most of us would look at that and say, well, of course it has to. And once again, this was maybe, I guess you could say, a little bit better than the evidence on step 1. But at the time, and what they really summarized in this document was that the available evidence at this point in time was limited and of poor quality. So once again, not to say don't waste your time training your staff, but just how do we answer this question? How do we develop the body of evidence that will adequately support this, give us the answer to this question? And so I think that's the challenge of how do we design these studies. Okay, so we're going to move on then and look at some other publications. This from our U.S. Agency for Healthcare Research and Quality, and they put out they do really extensive work, and this literally just came out last month. Their document that they titled Breastfeeding Programs and Policies, Breastfeeding Uptake, and Maternal Health Outcomes in Developed Countries. So hopefully, more specifically applicable to the environment here and the patient population here in the United States. So that's a picture of what it looks like. And there's actually the evidence summary, which itself is quite lengthy. And then there's the actual technical document, which is, once again, hundreds of pages. So, I've just, in trying to give you some, quick overviews of this and key messages. So the purpose of their review, they looked at the effectiveness of community, workplace, and healthcare system type programs and policies aimed at supporting and promoting breastfeeding, and to see, is there an association also between breastfeeding and maternal. So we're not looking at that today, but we are looking at, what did they determine as far as the association between breastfeeding outcomes. And so the key messages that they came up with, the first big key message they had was that the Baby Friendly Hospital Initiative is associated with improved rates of breastfeeding initiation and duration. So yay, there's once again more recent evidence after they've reviewed hundreds of studies and looked at systematic reviews and looked at quality of evidence and so forth. Now, a couple of other interesting messages that they included in their summary: healthcare staff education combined with some kind of postpartum home visit may be effective for increasing duration. Then they also said healthcare staff education alone with no additional support, so no support, after hospital discharge, may not be effective for increasing. And I thought this was interesting. The one looked at duration, and then the other looked just at increasing initiation. So, of course, some of that comes along with the step 3 prenatal education. So we can't wait until the mother shows up at the hospital to start talking about breastfeeding and then expect her to, just jump on, the train. So we've got work to do, and no matter how enthusiastic and how committed and how hard, our hospital team works, we can't make up for the lack of, prenatal education, or we can't make up for sending a mom home who's doing great, and then there's no support after hospital discharge. I think that's what those messages tell us as well. All right, so then let's look at, this is a publication that came out in Maternal Child Nursing, Rafael Perez Escamilla and his team of co-authors. So they did a systematic review looking at the impact of the BFHI initiative on breastfeeding and child health outcomes. So if we implement all these baby-friendly practices, does it really make any difference? Do we really see, any changes in breastfeeding outcomes, which of course ultimately would lead to improved child health outcomes? So once again, the key messages from their review is that they did see that there was a dose-response relationship between the number of the steps, the 10 steps that women are exposed to, and the likelihood of improved breastfeeding outcomes. So, and that really supports previous research and some research that I often cite that the CDC has published and reported on, is you can take any one of the 10 steps and have a small impact, but it's that package effect. It's the cumulative effect and the synergy between all of the 10 steps that, and as they say here, that dose response relationship. So the more steps in place, the better. The more steps in place, the greater the improvement and the likelihood of improved outcomes. Now, some also interesting things that they cited. They said community support, or your step 10, is really important for sustaining impacts in the long term. And to me, I absolutely appreciate that, because once again, we can do a really good job, work really hard in the hospital, but we have that mom for 2 days, and we hopefully have set a good foundation for her and her baby. But if she then leaves the hospital and encounters misinformation from other providers, lack of support, lack of timely support, then, all of that good foundation we set, may not help some moms, continue over to get around those barriers. So step 10 and partnering with community organizations can really have that greater impact that we'd like to see. I thought I fixed that little typo there. They also said that several, while they saw a trend in a lot of the articles that they reviewed, and they said that they cited that if they didn't adhere to step 6, if they didn't encourage exclusive breastfeeding, or to put it another way, if there was a lot of routine formula supplementation that was not medically indicated, then that was a major risk factor for poor breastfeeding outcomes. But they also went to great lengths to clarify, too, that you can't just take step 6 by itself and say, well, if that, because this looks like step 6 is the most important one of the 10 steps, so let's just work on that one and don't worry about all the other stuff. Let's just do step 6. But step 6 really is so connected with all of the other steps that you can't just pull that one out and try to just implement that one. That, as they said, it's likely to be a reflection of that we've actually implemented all of these other elements that improve breastfeeding outcomes. And so they're too highly interwoven and statistically correlated with each other to just pull step 6 out by itself. Does that make sense to everybody? I hope. But I found that interesting that they made the point of highlighting that in some of their conclusions. So then another very recent publication that came out in Breastfeeding Medicine, the impact in the United States. And now we're looking, so the Perez Escamilla looked at baby-friendly in developed countries, including the United States. This one looked at the impact just in the United States on early infant health and breastfeeding outcomes. So, and they took an interesting approach. So some of you may be familiar with this graphic of the social ecological model, and you can apply this in many areas of healthcare and public health. So you may have a health behavior that you're trying to impact, obesity, smoking, whatever. And so you look at what are the intrapersonal factors that influence that, individual person. And in this instance with breastfeeding, if y'all can, read on here, but, what the mother's, what does she know about breastfeeding? What are her beliefs and experiences, her perceptions of breastfeeding? So those intrapersonal factors. Then interpersonal and provider factors, what about support from healthcare providers? How well are staff trained and things like that? So they took that social ecological model and applied it to this to the Baby Friendly Hospital Initiative. So here's where they put, staff training and time and staffing ratios and resources. If the nurses have too many couplets on a mother-baby unit, they don't have time to help a mom with position and latch. So Bruce says, lost the audio for a few seconds. Can everybody still hear me okay?
Yeah.
Okay. Thanks. And then on up to what they typically call organizational, and that could be, your hospital factors. So is the hospital implementing the 10 steps? What kind of, do we have a written policy? So there's, what we're looking at specifically today. And then even systems factors such as, and I really appreciated this, how do we define breastfeeding? What is this exclusive breastfeeding? If we say breastfeeding at discharge, well, that's defined differently from hospital to hospital, which makes it hard to really measure those outcomes accurately, because one hospital may take breastfeeding at discharge, and that was what the baby was doing at the last feeding before they walked out the door. And another hospital says, no, it's what they did from the very first feeding to the very last feeding. So those are very different definitions. And excuse me, that's another phone ringing in the background. And the hospitals chart in different systems and chart in different ways. So, once again, trying to get that data and those monitoring pieces in place across, say for all the hospitals in the state, for example, it is really difficult. And especially if you're trying to apply that then to a research question. So anyway, I really liked this concept that they had. And so some of the conclusions that they had in their review of, once again, numerous articles, they did find that the more training that healthcare providers received, the more likely those individual providers and staff were to comply with not only the baby-friendly practices, but also, buy in or commit to the baby-friendly philosophy. So once they have enough training, they understand the impact and they get the why, which is often something that we're asked, well, why does it say not to do that? What's so wrong with giving a pacifier at 12 hours, of age? Well, let's talk about that. So the more training they have, the more likely they are to understand the why behind these practices. And similar to the other publication, there is a dose-response relationship. Does this sound familiar? With the number of baby-friendly practices implemented and improvement in breastfeeding outcomes. So, but they said that, the hospital really needs to emphasize consistent delivery of practices, not, well, we do this on certain days when certain staff are here or certain doctors are here, and then on other days it's a completely different picture. Very inconsistent practices. And they said that's where the policy piece really comes in. We have to have a well-written policy, and it has to be disseminated. People have to be trained, and it has to be consistently implemented. So you see how much time's down. Okay. They also said that we need more prospective studies. Once again, those randomized, controlled, prospective trials as opposed to retrospective. And so this is my question that I added, but how do you now randomize these practices? That is, I would love somebody to tell me, how to design a study that way. I think that's really, really difficult. We know enough about each of the steps that some of those are going to be very difficult to try to randomize. And, we're no longer going to, I'm sorry, Mom, you got randomized to the group that, we're not going to do early skin to skin contact and early initiations. Like, I don't think we could ethically do that. Anyway, and then they also, back to the social ecological model that they had, they said we need standardized charting of breastfeeding across hospitals so that we have the same definitions, and we can better track the outcomes across different systems, and and based on what practices are happening in hospital A versus hospital B, that we have such different outcomes. It's just really hard to answer that question right now because the data is so inconsistent. Okay, so last one that we're going to take a quick look at is just getting us back to kind of the policy question. I thought this was a really interesting one. This was in 2013, also in breastfeeding medicine, and it was looking at hospital policies in the state of New York and kind of what drove them to develop a model hospital policy for the state of New York. Now, I want to also remind us, and I'll have that on a slide here in a minute, that our COBA group, our State Breastfeeding Coalition, we have had a model hospital policy since for almost 10 years, 2009, and it was fairly recently revised. So that's certainly a tool out there as well. So it was fun for me to look through this article. But also know that the state of New York has quite a few state regulations that address maternity care practices and requirements for hospitals to implement certain care practices. And part of that involves the 10 steps. So they actually have that in their state regulations. So this group of researchers said, well, let's look and see how we're doing with that. If we've got it in our state regs and you can't get licensed, without, complying with state regulations, then all the hospitals should have all this in place. When they did a systematic assessment, they found that and they looked at hospital policies and practices, and they found that about half of the components that were required through state regs were included. So there was a gap already. And those weren't all specific to breastfeeding or the 10 steps, but, various other practices that they felt would improve outcomes. But they also found that the inclusion of each of the 10 steps varied hugely, dramatically, from 14% to 98%. So you might take step one, how many of the hospitals actually had, a policy that included the 10 steps versus, how many of the policies, how many of the hospitals are, had a policy that talks about early skin-to-skin contact or rooming in and so forth. So they found, huge discrepancy. So that led to the development of a group task force, if you will, with looking at the state regulations and legislation, what's required, and then putting together this model hospital policy that would meet all of those criteria, and also included what information they had from expert recommendations, such as the American Academy of Pediatrics, breastfeeding policy statement, and they've got a sample hospital policy, Academy of Breastfeeding Medicine, and so forth. And then lastly, once again, more research to identify, in this case, best practices to help translate those policies into systems changes, and more, fully ensure that those are going to actually be put into practice. So that was a really interesting one as well. Even having some of these requirements in their state regulations and so forth didn't mean that they actually got put into a policy, and didn't mean that they actually got implemented by the hospital. So here's my slide too, to just remind us, and those of you that may be wanting to update your policy or make sure it's fully inclusive of all the best practices and so forth. Here's a template that you can start with. So our coalition's model policy for the state was developed in 2009 and revised most recently in 2015. And the most current version was endorsed once again by the Oklahoma State Department of Health, our family physician chapter, and then our state AWON chapter. And you can go to COBA's website to download that, and that's a picture of what it looks like. So, all right, I am going to pause there for a second and just see if any questions from anyone. I'm going to see if there's anything in the chat box that I missed. And yes, or any comments from anyone. If you're in a hospital, it sounds like everybody that's on the call today has policy, either in place or maybe. Of course, policies should always be regularly reviewed and then revised as needed as new evidence, new information, new recommendations come out. So that's something Baby Friendly USA requires as well, that for your hospital infant feeding policy that you have information in there about how frequently is it reviewed and when was the last date of revision, or if it's a brand new policy or what have you. So you definitely want to include that in there. Let's see. So we have about 10 minutes left. So yeah, and if any questions, I hope this was helpful. It's kind of, once again, hard to, my initial thought was, great, I'll see what all the evidence, and then it's like, well, we need more research, and we need more research, and we need more research. So how do you, do your best to try to address these questions and with, the research that we have at the time. All right, so I am going to, move to a couple of, just 2 or 3 final slides with just some other upcoming events, continuing opportunities for education or trainings in breastfeeding that we offer. Once again, supported with some of our with our contract through the State Department of Health to improve breastfeeding outcomes. We have I do a 2-day training, breastfeeding basics and beyond, that we schedule quarterly, and we try to do 2 in the Tulsa area, and then 2 each year in the Oklahoma City area. So those are the last 2 scheduled for this year. Actually, one is next week here in the Oklahoma City area, and then just before Halloween in Tulsa. It's often at the OSU Tulsa campus, but that location has not yet been booked, I think. And then, of course, the 1-day Making Breastfeeding Easier training that we schedule and do here quarterly on the Health Science Center campus, but also this is one hospitals absolutely can request. And I will be doing, I just did this in Duncan recently, and we'll have some more of these coming up for some of our hospitals. And we can, absolutely, contact us if you're interested in that. Both that one is approved for contact hours for nurses as well, and and these are all no charge. Just contact us about getting something scheduled or getting staff possibly enrolled in that. And then lastly on here is the 15-hour online breastfeeding training that is available, and it does meet the Baby Friendly USA requirements for the 15-hour didactic piece of training. If you're a hospital that's enrolled in our BBFOK state project, then it's $30 a person, because that's what the university charges us to get people enrolled in the online program. And then outside hospitals, it would be a $60 per person fee, which is still very, very inexpensive for a 15-hour continuing education credit course. So you can email us at obrc@ouhsc.edu if you're interested in that. And then also just a note, I know some of you are have utilized or are familiar with BCEP, the Breastfeeding Continuing Education Program, and we were in the process of trying to manage that, and we tried to manage it for a year or so, and unfortunately just that was not working out for us to be able to maintain that and make all of the revisions and upgrades and things that it needed. So we made the sad decision to discontinue our management of that program. And Linda Miller and Judy Harris are longtime OB nurses who were, retiring and hoping, to have their program continue on. So at this point in time, I don't know that they, my understanding is that they don't have anyone else that is able to, purchase or take over the course for them. So what we are doing is any staff, if you had any of your nursing staff that were actually working through BSEP right now, to definitely contact us and let us know how many you have left, and we will do our best to honor and award certificates of completion to those nurses. But definitely check in with us, because and I'm not remembering the deadline. It might be that we need them to finish by the end of this year, of the end of 2018. So definitely let us know. All right, so some fun topics here. Just reminder, some of you probably already know that the Office of Perinatal, the Oklahoma Perinatal Quality Improvement Collaborative is hosting their annual summit. Usually that's in September, but due to some speaker conflicts and so forth, it's gotten bumped back to November. So that's on November 16th. But of special note is that they're doing a pre-summit on disparities, which I don't know that they had a speaker identified the last I heard, but so we're definitely very interested in that. And that'll be a half-day course that's, free to the, healthcare community the day before. And then our Becoming Baby Friendly in Oklahoma Summit is scheduled for February 22nd. We do have our keynote speakers identified. Kathy Carruthers, well-known lactation consultant and been a national leader in the field for many years. She's been president of the International Lactation Consultant Association, and she's been chair of the U.S. Breastfeeding Committee. So she's a great speaker, and she's really does a lot with kind of on the communication topic, which is sometimes a challenging one. And then Dr. Joan Meek, who I've had the pleasure to get to know over the years. And she is actually the current chair of the American Academy of Pediatrics section on breastfeeding, which some of you may not be aware, but the AAP's section on breastfeeding, and I don't remember how many, the AAP has thousands and thousands of pediatrician members, but the AAP, of all their specialty sections or, topic sections that focus on a particular area of interest, the section on breastfeeding is the largest one, and it has almost 1,000 members. So that's really a huge section. So, and then just, up here in the corner, we do have Sarah Bellotti, our administrator for OBRC, has been doing a great job of trying to keep our Facebook page a little more interesting and current. So she's been posting a lot this month for National Breastfeeding Month, and information and resources, and as we identify those. So definitely check us out on Facebook. We do have webinars, and this is the last slide for us today, but just a reminder that we have webinars. They're usually the second Wednesday of the month. This one was booted back a little bit, but those are always at noon on GoToMeeting. And we have the September 12th and then the November 14th webinars, which will continue this theme of the evidence behind particular baby-friendly steps. So we'll do steps 3 and 4 for the September webinar, and then steps 5 and 6 for the November one. So stay tuned on that. And then we've been working to resurrect our electronic newsletter. So our goal is to have that be our big information topic for October. So I'm going to open this thing back up, and let's see. So we are just about to the end of the hour. If anybody has any questions or other comments or announcements before we wrap up for the day. All quiet out there in webinar land. if anyone's never done a webinar before, I can tell you it's challenging when you aren't there in person and don't have that interaction with your audience. So anyway, well, I know we have busy times right now. Kids getting back in school and National Breastfeeding Month activities. So definitely stay in touch. Contact OBRC if you have any questions on trainings, and definitely, contact COBA if you have events or some fun things going on that you'd like to get on the COBA events calendar. Anyway, having said all of that, and if I don't see any other questions from anybody, I think we will wrap this up and let y'all get on about your day. So thanks for joining in. And we will see everybody in webinar land possibly next month. Thanks a bunch.